Hello, everyone. My name's Tracy, and welcome to Standard Imaging's Out of the Gray video podcast series. I am incredibly excited to get this arm of our project started to help spread these messages and these stories even further. For our listeners joining today from an audio podcast platform, please do check out Standard Imaging's YouTube page, where you can enjoy all of the visual content that's going to go along with these interviews. Without any further delay, let's get into this latest conversation. Hello, everyone, and welcome back to another episode of Out of the Gray, the podcast where we discuss all things radiation oncology and medical physics. Today, I'm excited to have with me Neil Duggar from the University of Mississippi Medical Center.
Sure. As you said, I'm Neil. I am at the University of Mississippi Medical Center. I have been here for about 10 years. I was the first medical physics resident at this site. And I I was glad for that to work out because I was born in Mississippi, so I'm a Mississippi native, and so I've got a lot of loyalty here. I did my medical physics studies at Georgia Tech and graduated my master's from there, and ended up coming back here for residency and never left. But it's been a good place, and I'm happy to be a part of making medical care better for the people of Mississippi. So,
Neil, thank you so much for taking time out of your busy day to join me here on the show and share your experiences with myself and our listeners. I know they really appreciate it as much as I do.
well, thank you. Thank you for having me.
Absolutely. I'll jump right in with the first question. I am curious, what did your introduction to medical physics look like? How did you end up wandering into this field?
Yeah, it was kind of funny. It wasn't on my radar in undergrad. I guess it was my junior year. I was majoring in physics, just basic physics, and I did this research experience for undergraduates and ended up at the University of Alabama in Birmingham. And some other students that were there introduced me to medical physics. And when I looked into what it was, it just resonated with me. I was like, wow, this sounds awesome. I really want to get into this. And so I started investigating and looking for opportunities, and ended up finding it at Georgia Tech, and basically immediately applied as soon as I that fall semester afterwards, and got in, and never looked back. So it just a happenstance introduction at a summer program, and then I sort of fell in love with it.
A great story, and thank you for sharing that little tidbit with us. I find it fascinating to collect stories of how people found the field, because and I know I see this a lot on the show, but it seems to me like it finds us. We don't necessarily find it, and it truly is interesting. And I do have a lot of students, listeners as well, who like to come check out the podcast and are searching for their own way forward. And I feel like these stories can help guide. So I appreciate you sharing that.
Sure.
Now, Neil, ahead of time, we'd had a bit of a discussion about things that you're working on there currently in your facility, and some very exciting things coming down the pike. What's new for you and your team there at the University of Mississippi?
Yeah, one of the big things that we're real excited about, and just we've just seen a very big impact on the way we treat certain patients, is in the last 2 years, we have started utilizing MRI and interstitial brachytherapy for cervical cancer patients. And it's really been a journey. It really started, the Embrace study came out in like around 2000. It sort of got on the map, on the radar. And we have a physician residency here, and we regularly sort of, they have to talk about different topics. And a couple years ago, one of them presented on brachytherapy, and devoted part of their talk to the value of using MRI in brachytherapy. We were not doing it yet at the time. We were totally CT based, and we got interested in it. another resident and one of our physicians sort of just looking at the data and looking at the information out there, just how big of an impact it has had in other places that have looked at their data and looked at their even their clinical outcomes. It was like, okay, we got to figure out a way to do this. Now, we weren't, we are Mississippi's only academic medical center, but we are not big and flashy or necessarily, like, we don't have unlimited resources. We don't have our own MRI suite in radiation oncology. So it was like this, doing this for our patients is going to be, there's going to be some logistical hurdles that we need to overcome.
Mm-hmm.
And so it was a long process, but we had several people that basically said, you know what, this is going to take more time, this is going to take more effort, but we believe in it, and we believe it's worth it. And the data is very compelling, but once you actually see it in practice and you see it on your patients, and if you're not using MRI, you can't really tell how extensive the disease can be when it moves outside of the cervix. And so you don't even realize what you could be missing if you're just planning based on CT. And it's not every patient, but it's enough that you could be doing essentially not enough for that patient and not even know that you're not doing enough for that patient. And so, and we have seen it. I mean, I have examples that we can talk about, but where it's just, you realize, wow, if I would have done this the old way we used to do it, planning to point A, we would have missed it. And, I mean, how could we expect to control their disease if we were missing part of it? So it's very impactful when you see it in front of you. It's more than just a number. It's more than just so-and-so saying that 3-year local control went from, 50% to 80% or whatever they tout. Like, when you see it on a real patient, it's like, wow, this is really important. I'm so glad we are doing this and we're looking at it.
It's critical.
Mm-hmm.
It's critical is to look at something and be able to recognize, had we gone the traditional route with this particular individual, an opportunity to control disease would have been missed.
Yeah. And I guess for me, what some of the impact, and I guess Astro came out with their newest cervical cancer guidelines in 2020. They published a new set. And one of the things that flagged me, and this is because of our efforts to move to MRI directed brachytherapy. But when they always, all the guidelines, they always answer key questions, right? And I guess I can share my screen for a second, but
yeah,
they
absolutely.
always answer key questions and give their recommendations. And there's something very striking when they offer their recommendations regarding the optimal imaging or optimal technique for brachytherapy. It's almost like they dodged the question, because they give a recommendation for intra-procedure imaging, okay, and then they say the second recommendation is you should do MRI or CT based volume planning. And then they say when you can't do it, you should at least do 2D point based planning. So, like, it's almost like they neglected to actually make a real recommendation. They said any of this is okay, but in our personal experience at our institution, we've seen that 2D point-based planning, for some patients, that is not going to do it. That's not going to cut it. And you won't even realize it while you're doing it. You'll think it's fine. You're getting your doses. And in fact, I can actually show you another, just to show you what I'm talking about. We actually we've looked at some of our patients. We looked at about 18 patients. This is a paper we published, and we looked at about 18 patients, and just kind of looking at how things were going. But we actually picked one of them that we kind of thought it really illustrated the importance of what you're of doing it this way, of doing MRI, not only doing MRI, but being ready to do interstitial brachy when you can. And so here's a patient that showed up to us, and we initially planned them with a traditional tandem and ovoid insert and had trouble. Let's see. We found that you're supposed to try to get 85 2 gray equivalent, or 80 to 90, it depends on who you ask, but 85 gray 2 gray equivalent to the D90 of your high risk tumor volume. But alternatively, like Astro would say, you can get 85 gray to point A, which is a well-known prescription point that people have used for decades. But in this specific patient, here we're getting over 85 gray to point A, which is the point-based planning. But we are only, like, with the traditional technique with no needles, and we've used MRI to contour the residual tumor that we need to make sure and cover, we're only getting 75 gray. So we're not getting enough dose to the tumor that's left behind. And so this was a big deal to us. We've seen, this is just one patient, but we've seen this on patient after patient. So if you just say, well, let's amp up the dose so that we get the 85 gray to D90 HRCTV, but then you can tell, like, so there are rectum constraints, which are recognized by Astro and Gynecological and all the brachy people out there, all the cervical cancer experts. You shouldn't go more than 75 gray 2 gray equivalent to your rectum. Well, that would have pushed us to 82. So using the traditional brachytherapy technique, if we had not been doing MRI-based planning, we would have gotten our point A dose and thought we were fine. We did MRI-based planning. We realized, okay, we're not getting the coverage we needed. So then we moved to a situation where now we add 3 needles to the elective Venezia applicator, so we can add interstitial needles and give us some more options for where we can place source dwell positions. And you can see that the final outcome was that we were able to get 86 gray to the D90 of the HRCTV, and we met all of our normal tissue constraints. And so it's the same idea as moving from 3D external beam to IMRT. It gives you some ability to shape your dose. And so you can avoid your normal tissue and add dose to where, you're missing your coverage. And so we just have seen that it's a big impact, and it's not every patient, it's patient specific. Sometimes we go through all the rigmarole of doing MRI, and turns out their disease is small and localized to the cervix. Now, you could also, one thing we have seen is that sometimes you don't even have to give full dose to point A. Sometimes you can treat all of their disease without treating point A to 85 gray. You can just treat the HRCTV, and you've treated all their disease enough. And so, there's opportunities, I guess, to de-escalate your dose as well. But it just, time and again, in real clinical practice here, we've seen that it makes a big difference. And if you're not doing MRI on your cervical cancer patients before brachytherapy, you're potentially not realizing what's going on there. And if you don't have the ability, or you're not trying to get the ability to do interstitial, then you may also miss. And I'm not saying that people that can't do interstitial or MRI even necessarily can't do brachy, but I am saying that people should be careful, are there ways that, maybe you can't afford to buy a fancy applicator, or you can't, you don't have good access to an MRI on a regular basis. Maybe there's some ways you can implement. Maybe you could refer them for at least a post-external beam, or, sort of towards the end of their external beam MRI, to get a sense of how advanced their disease is. And then you can decide, oh, we are going to be able to handle this patient because their disease is within the cervix, not parametrial. Or you can say, you know what, we really should refer this to somebody who can treat this level of, this extensive disease. Um, and that way you can make sure that the outcome is best for the patient. Because we've seen, based on the way we see it, it's somewhere around 20%, we've ended up deciding we needed to add some needles to. So it's not every patient. And truly point A and sometimes point A and HRCTV do line up as far as the doses that you give to both. But there are many cases where they don't. And so if you're not even looking at it, then your patients are potentially going to be the ones to suffer from that. And so it's just good to have some relationships, be aware of people, and try to have a plan. How are you going to make sure that this patient's getting the care they need? And maybe you're not the person to do, you're not the clinic to do it, but maybe you are. And just not everyone necessarily has to figure out the logistics of doing MRI directed interstitial brachy, but you do need to, I do think it's worth it to figure out how you can make sure your patients have that opportunity, and your parents too if they need it. but yeah, so it's just been very impactful. I've really appreciated the learning experience it's been for us, and just to see what a difference it makes. And I've really appreciated my team at UMC, just because it is a lot of extra work, it's extra money, it's extra time. But we've recognized, maybe a little bit late, I mean, a lot of our European colleagues have been doing this since the early 2000s, but we recognize that there was a need here, and that our patients could benefit from us improving in this way. And it took us figuring out some hurdles. Our radiology department has been amazing in the fact that they are willing to share their MRI time, because we don't have our own MRI in radiation oncology. So radiology is key in helping us not only acquire our MRI scans, but also reading our MRI scans so that we can make sure we understand exactly where the disease exists for that patient. And so it's been a great learning experience, but I also am very proud of the progress we've made in the quality of our treatment for these cervical cancer patients. So.
Absolutely. It's an admirable effort, without a doubt. But I am curious, is there any impact for the patient necessarily to travel down the route of adding an MRI to the planning regimen?
Yeah, I mean, that's a great question. I mean, yes, there is. I mean, different clinics do things different ways, but it is absolutely going to add time to the process, because an MRI just by nature takes longer to acquire than a CT, and definitely than X-rays. And then you got to spend the time to read it and make, and there's extra image fusions in the process, and taking the time to delineate those volumes. It is a more time consuming process than traditionally it has been in the past. And then also, if you have to add needles, I mean, those needles are going into the soft tissue of the patient. So, there are going to be some side effects potentially from that, and think that clinicians will have to be ready for. Historically, even when we were just doing CT-based planning, we historically did, we anesthetized our patients for the insertion portion. It wasn't just a local anesthetic; it was a full. We bring a nurse anesthetist on site, and she, and they're fully asleep, whenever they're getting the device implanted. So for them, they probably don't recognize necessarily the difference in the implant process, because even if we add needles, they might feel extra pain later, but during the process, they were asleep anyway. So
Yeah, seems like a kinder way to go.
Yeah. No, we definitely are big fans of the anesthetist. I mean, that's because even when you're doing it the traditional with no needles, it's still a very uncomfortable situation. So
Yeah. Yes, absolutely. And any level of comfort to offer a patient is appreciated by them and the group working,
yeah,
without a doubt.
but and we've gotten better at it, but I mean, we typically try to do one patient a day because of the extra time. Now we have done multiple patients in a day, but in general, we try to focus on one patient per day. Now that's another challenge, but that's also like, that's just us. We have the freedom to do that because of our patient volume. Busier clinics might have, there's always opportunities to streamline and improve and things like that. And, we're always on the lookout for that too. And we have, like for example, when we have identified a patient who doesn't necessarily benefit from MRI, their disease is localized to the cervix, then we have done CT instead for them in order to be able to have multiple patients in the same day, without having to have too much logistical juggling going on.
Yeah,
It
it
just
makes
depends,
sense.
but it gives you at least you have the opportunity to make that informed decision rather than just assuming everyone is the same. And, because not every, even if every patient starts off at a certain stage, but you really don't know where their disease is going to be after external beam is over, so you have to at least take time to assess what's going on there, to really decide what's the optimal brachytherapy technique to use.
Lots of decisions going into it, but clearly an effort in due diligence.
Mm-hmm. Mm-hmm.
Yeah. And rates of success, it seems. If you're controlling disease, you'd have to see an improvement there.
Yeah, I think there's a great, and in fact, I guess I'll share that really quick,
Yeah.
because a great place to go if you really want to see the impact, as far as the literature goes, would be the Embrace 2 study that was published back in 2018. And I'll just show it up here real quick so you can look at it. But they go through, not only what we've learned from the protocols that they did overseas, but also where they're trying to head in the future and what are the things they're worried about now. But if you talk to any of them, I don't think you'll get any sort of confusion, or I mean, they know what they'll recommend. And they talk about, I mean, just really quickly, I mean, you're talking about anything stage 2B and below, 90+% 3-year local and pelvic control, which, prior to image guided brachy, I mean, it's crazy, and then I've got another study from the Netherlands where they looked at, they compared traditional technique to once they started using MRI directed brachytherapy, and their overall survival at 3 years went from 51% to 86%. I mean, that is astonishing, right? I mean, and so, I mean, that's what convinced us. And that's why we realized this has to happen, and we ran into plenty of hurdles and, probably wanted to give up a few times, but it has been such a rewarding experience, and we feel so good about the care we're able to offer the patients. So,
As you should. Admirable, to say the least. And I'm curious, of the hurdles that you did approach, what might have been the top three difficult spots to traverse to implement a practice like this? And then to follow that, how were those challenges met?
sure. So probably the first hurdle is, how are you going to get your MRIs and when are you going to get your MRIs? And that's where, we actually had a dinner meeting with radiology and a couple of their manager and their, one of the radiologists there. And, we just sort of hashed out, how where we'd like to be. And they were very gracious and helped us and basically felt like they could be with us on that. And so they, because I'm not sure, but my understanding is I don't think they get extra money necessarily from these scans. They might. I'm not sure exactly how that works out, to be honest, but they do, they are sort of donating their MRI that they could be using for diagnostic scans during those times. They're giving us a slot on a regular basis. And so that's a lot of graciousness and generousness on their part, but so that was huge, figuring out how we could theoretically do MRIs was good. Now we started off trying to do we were like, well, let's try to do CT on the day of implant and then just use MRI from before. And you can do that, but there's a lot of when you put the applicator in, it changes a lot. How the tumor is sitting and laying, especially related to the applicator. And so we kind of came to a consensus early on that we were like, well, we'd like to get at least one MRI with the applicator in place and know, how that geometry is sitting for that patient. And then, so that was kind of, just figuring out the MRIs was probably the biggest thing. And, currently we've gotten to a place where we pretty much have a good system going where we get MRIs we plan initially to get MRIs for every treatment fraction. And that has pretty much been a reality. And that's been because of the, coordination between our department and the radiology department. But we don't necessarily get new radiology reads every fraction. A lot of times we'll just see, we'll adapt what we learned the first fraction to the new fraction. And, sometimes it's changed, not usually a whole lot, but then we can, we have confidence that what we're treating today is what is currently the HR. But then I guess the next big hurdle is the whole planning process, just the fact that you got to delineate all these extra tissues and then you have to figure out, point-based planning was relatively easy. You can just normalize and do a quick optimization. But then once you had to figure out how to optimize a brachytherapy plan to cover a volume, and then how to make sure that that was a good plan, they took some time and effort to really get a sense of, what are the metrics to evaluate a plan? What are the goals and objectives you put into your optimization to try to get a good plan? And it took, and there were issues because sometimes you're mixing and matching, like for example, our brachy planning is terrible at contouring. And so we were using the MIMS, but then that involves like moving structures around, and sometimes systems don't like each other. And so then that would cause issues and delays. And so that was a challenge. And then the other big hurdle for us that I can recall is when we would get a patient that wasn't achievable to get the plan that we wanted without using needles. Then how do we figure out what needles do we need to add where and all that kind of stuff? And so we have sort of had to because initially it was like, oh, well, now we don't know what to do because we don't know how to cover it now. And that was like, we didn't really get into this thinking we're going to do interstitial brachy. Like we got into it thinking we were going to do MRI directed brachy. And then that opened our eyes to the fact that some patients, that's not enough. You got to add some more to that applicator in order to get what you need or get what the patient needs. And so I guess, all of that is kind of related, as far as the two challenges. So dealing with the whole planning process becoming much more complicated, and then dealing with, what do you do when you need to add needles? I mean, it was really just a lot of back and forth, a lot of, evaluating, okay, what went well today, what didn't go well, how do we do better next time? And we were able to, now we got it to where we can streamline things. We've got structure templates, so everybody knows exactly what to contour and what should be included in that contour. They know how to coordinate with radiology, so they get their read in an efficient manner, and they're ready to come back and contour that high risk target volume. And then while we've gotten to where, because they're using a different system, we can set up the treatment plan, mapping the catheters and mapping the applicator in the planning system, and just have it all ready to go, so that when they finish their contours, we pull it in and we're starting from essentially a basic plan, and we can modify it and see what we need to do to get the plan that we want. And then, just of course, learning the tools. It took some training from the vendor. We called the vendor, and we're like, hey, we're dealing with this now. We need your help on how to do a good job here. And also, looking at what other people are doing. We called, that's the other thing, is so nice. There are a lot of people, if you're trying to figure something out, a lot of times, we were not inventing the wheel here. Like, the people had done this before us. And so we had, some of our physicians had certain people on speed dial that they could call and be like, hey, we're seeing this, how do we get past this? And that's physics, that's radiation oncologists, all of them were guides to us at different times. And then as far as the needles cases, essentially what we ended up doing, because package time is important for these patients too. So you don't want to waste an insert if you don't have to. So essentially the consensus we ended up coming to is, for the first fraction, we get whatever we can get in there with a traditional implant without needles. And then we will always use the Venezia that's just unloaded with needles, so that we can actually, they have a applicator model library in the system we use. So we can map that, and it actually shows us where the needle positions are, and we'll sort of simulate the needles going through the target, and we can tell, okay, this is where we need more dose, and we can add that in virtually. So, and what we were excited to figure out is that, really there's not, you can get a pretty similar insertion for the same patient from week to week most of the time. And so our dry runs ended up being pretty accurate. We knew how far to put that needle in, and we knew where to put the needle in. And it really kind of helped us have a plan for the next 3 fractions, so that we were able to make up the dose we missed on the first fraction. And also we were able to be ready to optimize the shape, to exactly what we were hoping. And so it was a good situation. Although another thing too is, bowel prep is key, so you really learn, like, especially when you're putting needles in, you want stuff out of the way as much as possible. And so, we've even gone so far as to, we sort of proactively implant put in rectal tubes to try to reduce gas, to keep things out of the way, and so little things like that you learn, that you can deal with, prevent issues later on. Because, when if a patient's normal tissues are sitting right on top of your volume, you're going to have a lot of trouble, even with brachy, getting your dose in there, and it falling off fast enough. So anyway, that was kind of long-winded, but
No, it's
there you
great.
go.
So insightful. It sounds like, there are definitely some steps and some things to contemplate and get around and work through, but once implemented, it sounds truly like a well-oiled machine. There's details and protocols and templates, and you guys have quite a bit going on, but it seems to be highly effective and an amazing service to offer your patients.
Yeah. Well, we have our good days and our bad days, but we are always learning, and we're always trying to get better. So, and the other thing that we've learned is, you can think you have it all figured out and you got a good system, but then there's going to come another patient who, you're going to have to, it's going to be a whole different ball game, and you got to figure it out. So, but that's, we know that now because we're using MRI, and we can, before we weren't really as aware of it, so.
Yeah. Growth and education and learning happening all the time. I look forward to seeing more folks have questions about how to add MRI to their protocols and implement these new procedures as well.
Right. and there's a lot of good resources out there, especially there's several good papers about, like some of the practical aspects, even down to what MRI sequences you need to be getting on your patients and things like that. There's a lot of good guidance out there because for whatever reason, and I mean, I think it's because of how hard it is to do this and also limited resources for most clinics, but volume directed, MRI directed brachy hasn't really taken off like perhaps IMRT did. And, and to me, I kind of think of it as a similar vein, because it offers a lot of opportunity that wasn't there before. But I think it just logistically, it can be challenging, but people have been doing it, and there are good resources into how to overcome a lot of hurdles that typically people, if you first start thinking about it and be like, oh, well, we don't have access to an MRI, or, oh, well, it's going to be, it's not really necessary, or, it's going to take too long. But people have published exactly the kind of things that you asked me what challenges we had to overcome and how, like people have published similar conversations, trying to say, this is how they overcame this stuff and what they do now and things like that. So
Yeah, I know the stumbling blocks of implementing any new procedure, policy, anything like that into a facility. The major stumbling blocks are felt across the board. And if you can share, how you got around one roadblock or
yeah,
two, it's always helpful for other facilities. I found that when working as a clinical therapist myself, you come up against a wall and somebody has already at least bored a hole through it. There's some type of knowledge to be gained. And the resources you're referencing are publications, white papers, journals.
yeah. So I referenced the Astro cervical cancer guidelines.
Mhm.
Those are on the Astro website. And then the Embrace 2 study was published back in 2018 in Clinical and Translational Radiation Oncology. That can be found on PubMed, I'm sure. And then we published a paper on Curious back in last year, I guess it was. And that was just sort of our looking back. It's pretty we had only done 18 patients at that point, but just learn, things we'd already learned, and just how really I think everybody was just on the same page of just how meaningful it was for certain patients. I mean, for us, about 20%, like if we were still doing it the old way with CT and point A planning, they would not have gotten what they needed from us. So, and that meant a lot to us. 20%, I mean, 1 out of every 5 patients, right? So it's just no good. So
And that's exactly where my mind went too. You see a list of 5 patients and one is a miss.
yeah,
That's
yeah.
an impactful
And
change to make.
it makes sense when you look at the outcome changes. I mean, when you go from 50% to 80 something percent, depending, and that's regardless of stage, and then just seeing the control rates, like it makes sense that it's somewhere around 20% need that extra oomph, and if you're not using MRI, you don't even know that. So
Incredibly impactful stuff. I really appreciate you taking time to share these findings and to shed additional light on such an important part of what we do every day.
yeah, well, thank you so much for giving me the opportunity. It is a topic I'm passionate about, and I'm excited to get to talk about it. So but thank you for the chance.
Certainly, my pleasure. Folks, if you are still listening or still watching this very first in our video series here at Out of the Gray, we certainly appreciate you spending time with us. Please do click that subscribe button and continue on our journey around the globe, picking the brains of the best and brightest and asking them all kinds of questions about their experiences. We've had a blast having you with us today, and we look forward to seeing you next time. Thank you so much and have a wonderful day.